Okay, Dennis, you may begin when you're ready.
Thank you, Mandolin. I'm Dennis Cauchon. I'm president and founder of Harm Reduction Ohio, which was founded in 2017. And welcome to this important panel. I think it's going to be very interesting and say a lot about the future of harm reduction. I think that Amanda Lynn may have already told you to for the question and answer period, if you could put your comments on Facebook comments or in the Zoom chat, then we'll answer them after the panelists talk. So we have three pretty great panelists. Christine Minhee, who's a lawyer and founder of Opioid Settlement Tracker, who has actually taught me more about the Ohio opioid settlement than anyone else, but now I'll fake in this presentation like I know what I'm talking about. And Scott and Wes Weidle, who are impacted family members who lost a son and a brother, and wrote a wonderful book that you should check out on Amazon about the experience. And we'll give further details later. And Dr. Mark Hurst, who's the former medical director of the Ohio Department of Health and the former director of the Ohio Department of Mental Health, recently retired a little over a year ago. And Dr. Hurst holds a special place in my heart because he was doing harm reduction when harm reduction wasn't cool like it is now. He was doing medication assisted treatment and all that stuff, you know, when it wasn't popular within sort of the bureaucracy. So I wanted to start with a brief explanation of how the Ohio opioid settlement will work. And Ohio, as Christine will point out, is slightly different than some other states, for better or for worse. So the basic amount that we're talking about here is a little over $1 billion. And important to know is the payments are spread out over time. You don't get that $1 billion up front. And we'll go over the payment schedule in a little while. And there's two parts. The base payments are guaranteed. We get them no matter what. Then the incentive payments are added if Ohio meets specific targets. I believe it's likely Ohio's going to meet almost all the targets. So we'll get close to the full amount, if not the full amount. So I'm going to, for most of this, treat it as if we get the full amount. Nothing is guaranteed in politics, but things look good financially at the moment. So this presentation is going to focus on two of the settlements. There are actually multiple settlements going on, but right now, pretty much the done deals that are going to bring in the billion plus are the distributor settlements, which a lot of you people know about. Cardinal Health, which is based in Dublin, Ohio, just outside of Columbus. McKesson, which is based in San Francisco, and AmerisourceBergen, which is based just outside of Philadelphia. They're the three big wholesale distributors who provided the opioids to the pharmacies. And then the opioid manufacturer, Johnson & Johnson, or J&J, has also sort of agreed and is part of this. It's about 800 million for the distributors and about 300 or so million for Johnson & Johnson. Not included, because it's still working out, is Purdue Pharma, which, as you can imagine, is pretty important, and the Sackler family as well. McKinsey & Company has made a settlement. They were consultants who helped market. However, that's not in here because it's going into a different flow. And then the drugstores, as some of you may know, CVS, et cetera, Walmart, are actually on trial right now in federal court in Cleveland. So they're actually challenging the settlement. So in total, I think as everything works out, Ohio should get about 1.5 billion, maybe a little more. So it's really a substantial amount of money that can really make a difference. So who will get the money? The Ohio Agreement divides it up among three government entities. The One Ohio Foundation is a not yet created, not yet in existence nonprofit. It'll be a 501c3 nonprofit, and it'll get most of the money, 55%. Local governments will get 30% of the money, and the state of Ohio will get 15%. So how will that divide up from this settlement? You'll see when Ohio will get like 500, 600 million, but then add on to that the Purdue Farmer and the other settlements. Local governments will get maybe 300 million, and the state of Ohio will get 150 million. We'll discuss it later, but like One Ohio is sort of a blank slate. It doesn't have bylaws. It hasn't been created. How it's going to be spent in local governments for political reasons, the money will flow directly to 2,100 local subdivisions. You know, there's a lot of governments in Ohio, and I just noted that that more than 2,000 of them will get less than 400,000 over 18 years. 1,900 of them will get will get 100,000 or less over 18 years. So you've got like Perry Township in Pickaway County that's going to get $50 over 18 years. So I think or like Hamilton County and Franklin County will get 11.5 million. So I'd encourage like harm reduction activists to go to their local governments and suggest something to do with the $1,000 or the $10,000, because they're not, you know, it's there and it's going to be somewhat limited to this purpose, but it's hard for governments to spend such small amounts. The thing that is sort of being encouraged is just, oh, give it over to the One Ohio Foundation and let them handle it, which might be a good option. The state of Ohio option, maybe Dr. Hurst knows more than me. I've been trying to find out who will control it in the state of Ohio. The language seems to imply maybe the Attorney General does, or the governor does, or the, you know, Recovery Ohio in the governor's office, or maybe legislation will decide that. But these are the type of uncertainties that I think are going to be profoundly important. So take a look at the cash flow, and you'll see that the distributors pay over 18 years. Johnson & Johnson pays over 12 years. And the Johnson & Johnson settlement, Christine will correct me if I'm wrong, has a balloon payment in the final years of 186 million. Which worries me a little bit, because it's 186 million for Ohio, but you know, like it's 2.5, 3 billion for the whole country. If I was a chief executive, I'd be setting up my bankruptcy for 2032, you know. So it's hard to say. It's just a little bit of uncertainty. And take a look at the total payments, which I'll actually, so you can sort of see these are millions of dollars every year. And to get a sense of how important they are to our response to overdose and overdose death, the state opioid response grant, the big federal money, $1 billion plus, is about 96 million a year in Ohio, and up from about 45, 50 million. So when you add in Purdue Farmer and all this, this is like a perpetuation of the biggest response that we've had to the opioid crisis. And Dr. Hurst may seem otherwise, but from what I can tell, Ohio has had a hard time spending that much money. Not because there's not enough things to do or because there's not enough good ideas, but turning around this massive amount of spending effectively on short notice is very difficult. So for the state opioid response grant of 50 million and 96 million, the state perpetually or has asked for extensions for extra 2 or 3 years. So even though I think that they want to spend it well, it's a challenge within a bureaucracy where you have to do competitive bidding, put out a request for proposal, et cetera. All those are really challenges on how to spend it wisely. So people on this call who are harm reduction might think the need is so great. If we even had $10,000 or $5,000, we could do so much. But it's really challenging to get this amount of money and put it out through, you know, through the structure that exists, especially to do it wisely. And as you know, income streams, like how do you compare a 12-year income stream that J&J is doing and the distributor's 18? million. So the way you do it is you just do a financial calculation, do the net present value. You know, when you win the lottery, you know, you can take your $1 billion over 30 years, or you can take a $500 million up front. So this is essentially the lottery $500 million. And I use the same estimate that the Ohio Public Employees Retirement uses on estimating like their value for the pension. So essentially what we're getting is about Ohio's getting cash value in these promises, assuming everything comes through, including the balloon payment of about 650 million plus. And that's really a substantial amount of money. And it's almost good, I think, that it's spread out over time, because it's really hard to spend that much money. So, you know, the net present value is really the smart way to look at it. And so I'll just got a couple more slides. The One Ohio Foundation, as you notice, I spell it as 2 words here and 1 word elsewhere, because the governor's office and the attorney general don't agree on how you spell it, which I'm afraid might foreshadow what happens with this $1 billion down the line. Could be wrong. So the nonprofit corporation hasn't been created, but in the legal agreement, it will have a 29-member governing board, which says to me the executive director is going to be very powerful, or like a 29-member board is very challenging to run it. It'll all be controlled by government officials, 10 from the state government, I think 5 appointed by the governor, 1 by the attorney general, then legislative leaders will each get a proposal. Then there are 8 urban counties that will have regional appointees, and then 11 non-urban sort of rural counties. And the way that's being done is not specified in the agreement. So behind the scenes, they're not taking applications. It's they've asked the Ohio Township Association, the Mayor's Association, to informally, just like behind the scenes, figure out who should be on the board and how this should happen, which to me is a little problematic, because I think this should be more transparent. Also, there's a 9-member expert panel that will be consultants who could be extremely powerful or not powerful at all. And I've been encouraging like the true experts like Dr. Hurst and people at the universities to get on that expert panel, because the elected officials who are on that panel are very busy and they want to do well, but they really depend on experts to know. The memorandum of understanding requires that the money be spent on evidence-based things, which is very pro-harm reduction. So there are 19 regions, you know, 21. So the money's flowing to 2,100 local governments, 19 regions at One Ohio. And the rough plan is that, all the regions will get about equal amount of money based on overdose death and population. So that's going to be challenging, although the One Ohio Foundation can keep the money itself. So you don't know, there could be a lot of politicking, but each of these 1,900 regions will have its own governing board. None of them has been set up. None of them has bylaws. So when you're talking about a clean slate, it's a clean slate at every single level of government. You're tossing $1 billion to government with like really no plan. I think everyone's well-meaning, but if you've ever tried to put together a family reunion or a wedding, you realize life is complicated. And I think we're going to have a hard time getting money out the door in the early going, which is not necessarily a bad thing. It could be, but I do think that a lot needs to be thought about how the process will work. And I encourage harm reduction people in Region 10 and Region 18 you can't really get involved in now because it's a secret, like who's going to be doing it. But once that comes out, I would encourage everyone to try to serve on the boards, because you have an influence and they need your input, especially if you've been impacted. One thing that the lawyers didn't think of, none of these boards has any requirement that the impacted population be included in any of the decision making, which I don't think is acceptable. Can you imagine like $1 billion for civil rights that had, or racial justice that has no Black members on it, or AIDS that has no gay members on it? And it's sort of like shaping up to possibly be problematic. You know, I hope I'm wrong. So let me get to the real experts.
Dennis, I apologize for interrupting. Would you, Facebook Live has ended, and I would like to fix it. Could you make me host real quick? Sorry for interrupting everyone.
I certainly will. How shall I do that?
Where it says make me co-host, just if you click on the top right corner by my picture.
Got it. I can make you host. I'll make you host.
Yes.
So you are the host.
Wonderful. That should fix it. Go ahead. Sorry, everybody. Thank you.
Thank you. So our first panel is Christine Minhee, who, as I indicated, like really has taught me a lot. And she's a Soros Justice Fellow who I think has funding specifically to do this, which I was overjoyed when I saw someone was looking at it, because even Ohio specifically, it's so complicated. And opioidsettlementtracker.com is her website. It's a wonk's dream. She's a visiting scholar at the University of Washington in School of Law, where she is now. And that's where she got her law degree. Undergraduate, she went to Stanford University. And she's the co-author of an article that I wish I had written, The Cure for America's Opioid Crisis and the War on Drugs. But I may arrogate that title sometime. So I appreciate you being here, Christine.
Dennis, thank you so much. That article has a hilarious backstory because I kind of bet to myself, could I write an argument for the legalization of small amounts of recreational heroin and get it published by Harvard Law School? And the answer is yes. You kind of have to Trojan horse it in there. But if you ever want to read a cogent argument as to how ending the war on drugs might actually save lives, I refer you to that piece. But Dennis, thank you so much for that kind introduction. Yes, I run opioidsettlementtracker.com. My job is to sift through Google alerts about the opioid litigation and the settlement spending issue every day. So I'm a little bit harebrained when it comes to everything opioid litigation related, but the benefit of that is that I have this macro perspective on states' plans because I've been tracking them for so long with Johns Hopkins. So I have a sense for when states' plans are unusual or when they're pretty like normal and kind of basic. And I'm very eager to talk to you about things I've noticed about Ohio. But before I do that, I want to jump into a big picture explanation, right? I would like to zoom out a little bit and give you the big picture of the opioid litigation as a whole, because our discussion thus far has focused on what's called a global or national settlement offer. And it's a specific one. It's one worth $26 billion from a specific set of defendants, the big three pharmaceutical opioid distributors, McKesson, AmerisourceBergen, and Cardinal Health, as Dennis has mentioned. So whenever you hear about global or national settlement in the news, just know that it's typically going to refer to a specific thing. And it's that $26 billion offer from the three big distributors, and then the states, get various amounts, and Ohio's getting a lot of it for reasons that I will jump into here in a bit. Dennis's slide explaining who's on the hook for that sum is absolutely correct. This deal does not settle, nor does it relate to things involving the non-offerer companies. So like the pharmacies are not McKesson, AmerisourceBergen, Cardinal Health. So this deal doesn't relate to them. It also doesn't relate to the Purdue's bankruptcy proceedings, and neither does it relate to Mallinckrodt. So to kick off my portion, I want to explain why it's called a global or a national deal, even though it's seemingly kind of piecemeal and incomplete. And in general, I'm going to move at a really quick pace because I have 15 minutes. If I get done early, that'll be a blessing and more time for questions. But if there's ever anything I'm saying that just doesn't make sense, feel free to ask me in the Q&A. But then also Christine at opioidsettlementtracker.com is my email. So you can just email me whenever. So the reason why the opioid litigation is so freaking confusing is because there are two sets of government plaintiffs suing the same set of pharmaceutical opioid manufacturers, distributors, retailers. There are two sets of government plaintiffs suing the same set of defendants at the same time. They're proceeding in tandem. The state AGs are suing their state courts, and then the cities and counties' local cases, even though they might have started in a local court, they've all been lassoed together for organizational purposes under the federal multi-district litigation Litigation, which you guys might have heard about because it's based in Cleveland with Dan Polster at its helm, Judge Polster, who actually is a pretty kind guy. So of that superset of companies the governments are suing, McKesson and AmerisourceBergen and Cardinal Health has made a $26 billion offer, as I've mentioned. 42 states have accepted it, including Ohio. And even though this offer only relates to those companies, the reason why it's called global or national is because it does settle cases by both lines of government plaintiffs. It captures both lines of litigation in tandem, right? So it'll settle the cases by state AGs against those three companies, and then also it'll settle the cases by the cities and counties against those companies as well. People make the comparison between the opioid litigation and the big tobacco litigation all the time. I want to talk to you a little bit about like why that's true and why that's not. So in the big tobacco litigation, so in the 90s, plaintiffs there were primarily state governments suing the four biggest cigarette makers in the US, which means that the big tobacco master settlement agreement is effectively a contract between 46 states attorneys general and four manufacturers. But here now in the opioid litigation, in contrast, localities and states are suing in tandem at the same time. And together they've cast a litigatory net over an entire supply chain. So not just manufacturers, but the folks, the companies that distribute the opioids to the retailers and then the retailers themselves. So you can see just based on the scale, how much more potential there is for political infighting, I suppose, especially with billions of dollars on the line, and especially with America that's been bleeding chips at all levels of government for quite a while now from dealing with two public health emergencies at the same time. So, that's the big picture overview. And I want to dive a little bit more into, this global settlement agreement, which is the topic of our conversation today. A little, just a brief update where we're at nationally. Whether this deal is finalized like nationally, like in the grandest sense, really depends upon how many of the participating states, localities sign on to it. So now is about the time you're going to see a bunch of news articles about state governments trying to get their cities and counties to say, all right, like you guys have to give up your opioid suits and join on. Otherwise, we're not going to get our maximum amount of funds. Dennis's slides provide the excellent technical explanation. Side note is that not every state has a Dennis, and not every state has set up, like a team or an agency to come up with information that'd be useful to distribute to cities and counties as they make their decisions. As far as informational assets go, like Dennis's slides and the numbers presented there, they aren't like readily Googleable. He's crunched them himself. And that's a massive asset you guys have in your state, because not all states have as intellectual number crunching prone good Samaritans to do this work for the municipal officials who have to make decisions here in the next couple of weeks. So hats off to Dennis. Those slides are excellent. They do provide the technical explanation, but the key takeaway from the slides is that in order for a state to maximize its share of that global settlement, they have to do some homework. Like they have to convince their cities and counties to put down their guns, so to speak, surrender their litigation and sign on to the deal. So that's where we're at nationally. The deadline for states to do that is January 2nd. This doesn't really apply to Ohio in possibly the coolest way possible, because where you guys are at specifically, Ohio specifically, as of September 16th, there was an $808 million deal announced between the state of Ohio and McKesson, AmerisourceBergen, and Cardinal Health. This deal is better than what you guys would get if participating the national settlement timeline alongside the other states, primarily because these companies have to pay your guys' attorney's fees, which roughly calculates $42 million. Other states don't have that advantage when they're settling with this other framework. You guys are settling early, so you guys have preferential treatment. And more importantly, settling early and separately, this means you guys are going to get your money ahead of all other states, possibly as early as November is the language from the AG's office. Every other state, April 2022 is the absolute earliest. So it is true when Dave Yost says that Ohio is first in line in the country to get the money. That is absolutely true. The reasons why you guys are getting the special treatment you guys had a trial date, Minhee, against these companies. It was supposed to kick off and the deal was announced, actually. So in litigation and gamesmanship there, if you have a trial date that you can, trial dates lights the fire into the asses of parties in litigation, encourages them to settle to avoid the time and expense of, trial and actually running litigation in real life. So the fact that so many of your localities signed on to the One Ohio plan early means that your state effectively did that homework assignment early, and McKesson, AmerisourceBergen, and Cardinal Health are like, this is great. All right, we'll settle with you guys early, give you the money faster because you guys have your stuff together. You state government, you've managed to get your localities in line far more quickly than every other state in the country. So there you go. Really briefly, I want to address how One Ohio fits into global settlement negotiations at all. How does the global settlement relate to all these state plans that are out there, the memorandums of understanding, the special funds, the stuff you've been seeing maybe. The way that it relates, and this is important. So if states who've opted into this national $26 billion deal, if they don't take any other action other than simply agreeing to partake, they'll be subject to pretty draconian default allocation rules. For example, so if they just say, yeah, we'll participate, and then they don't take any other action, they'd have to give 15% of their opioid settlement funds to the state government. They'd have to give 15% to the localities, and then reserve 70% in an abatement fund, control over which might also rest with the state, depending on the state. Indiana is a state that falls into this category where they just said, hey, we're in, but we're not going to do anything about it. And now all the news alerts I get about Indiana are how its cities and counties are really, really mad that they're only getting 15% of it. So states can deviate from this 15-15-70 breakdown that's baked into the global settlement agreements documents. They can deviate from it by doing one of three things: enacting an allocation statute, a statutory trust, like a special opioid fund, like a separate bucket to hold the money away from the general coffers, or a state subdivision agreement. And an example of a state subdivision agreement is actually the One Ohio Memorandum of Understanding. So, which is all to say that the One Ohio plan, regardless of how it's spelled, right? Because to Dennis's point, I think the AG's office and the governor's office have not yet decided how it's going to actually be spelled. And side note is that I used to work in marketing, and when different teams within a corporation would spell a particular project differently, it was kind of a sign of a lack of like reading from the same sheet music. So Dennis, your kind of foreboding prediction is not, it does make sense to me. Hopefully there will be some good further collaboration between the AG's office and the governor's office as you guys go about spending this money. But in any case, that's where your One Ohio plan comes into the picture. It's an attempt to deviate from that 15-15-70 breakdown. You guys are pursuing 15-30-55 thing instead. That's referenced in the slides. I'll let you reference it further detail. But for now, I should say, I mentioned that I'm doing some work with Johns Hopkins Bloomberg studying what states are doing to deviate from these defaults, if they're deviating from them at all. Some information for you, fun facts. Of the 50 states I'm studying, so I'm not studying the territories, unfortunately, at this stage of my research, but it looks like 30 states, so the majority of the states in this country have done something in anticipation of the receipt of funds. 23 states have enacted legislation, either a special fund to hold the money separately, or an allocation statute to say, hey, yeah, that 15-50-70 thing, that sucks, we're going to do something else. 12 states have come up with statewide allocation agreements, like One Ohio. And then 14 states are quiet. They're just crickets. I don't really hear very much from them. 4 states have something in the works. 2 states have come out to say, you know what, we don't really care. Like, this is going to exist in our general coffers and our legislature is going to control it. And we're not going to change anything about that. You'll note that those numbers don't add up to 50. And that's because some states are playing double Dutch. They're pursuing both legislation and also statewide allocation agreements. Whether or not that's good or bad, it's not really apparent now. It'll all play out in how states spend the money in the years to come, right? Because what we've learned from big tobacco is that years down the line, when state governments don't think folks are watching, or when state governments don't think folks care anymore, there is an added incentive to use the money to fill things left by budget cuts, right, to fill potholes and things like that. So, which underscores the importance of watchdogging efforts. Dennis is a huge, I would say that Dennis falls into the grand spirit of watchdogging. The numbers that he's crunched have been more elucidating than what's come out from like the plaintiff's executive committee and the litigation, for instance, truly impressive. And this is also why I'm just so desperately disappointed that One Ohio does not include reporting requirements. Arizona is a state that incorporates reporting requirements into its statewide agreement, which is to say that if the state of Arizona or its regions misspends the money, they have to report it, and there are consequences for misspending. They don't get future disbursements of funds. So in other states, if you spend the money poorly, you have to report it. There's a reporting mandate, and if you spend the money poorly, you won't get money in the future. Ohio does not do that, which is one of the things that strikes me as a little bit disappointing about the memorandum of agreement. But I think that, here I'll talk about, if I do still have the time, and I'll listen to the moderators to, I'll take my cues from the moderators. But I'd like to mention two things I noticed about Ohio that strike me as a little interesting, right? I mentioned I had that macro perspective, and I have the spidey sensor when a state is doing something kind of weird. So I want to point out to you two things that I noticed about Ohio that just really stand out. So the first is the fact that, and this doesn't relate to spending specifically, it relates to litigation broadly. There isn't a single state in this country positioned more advantageously in the opioid litigation than Ohio, period. That's a fact. The simple fact that the multi-district litigation, which again is that federal litigation like device that collects all the local cases and organizes them in like a central fashion, that federal multi-district litigation, which is a very big deal, it's based in Cleveland. What does this mean? This allows Judge Polster to preferentially select Ohio counties as plaintiffs for his test trials. This happened in 2019. Summit and Cuyahoga counties famously settled with McKesson, Marisourceburg, and Teva for over $260 million, like 6 hours before opening statements were set to begin. In September, there was a looming trial date against, Ohio had a looming trial date against McKesson, Marisourceburg, and Cardinal Health. Again, trial dates promote settlement and efficient settlement action. And that's worth $808 million. And now Lake and Trumbull counties, as Dennis had mentioned, they're actively in trial with the major pharmacies, CVS, Walgreens, Walmart, Giant Eagle, Rite Aid settled separately and before trial. And according to a plaintiff's attorney there, each county is asking for over $1 billion. Whether or not they're going to get it, probably not. But you can see how having the federal judge in charge of the multi-district litigation, and that allows him to pick his own counties as test plaintiffs, I suppose you can see how this has really benefited Ohio in the long run. The other thing, your guys' state AG, I'm always a little bit skeptical of Dave Yost's rather kind of absolutist take on the constitutional supremacy of states over localities. That's an open question. So when he says that states can force their localities to not sue big pharma companies, that's actually an open question. So don't take that too seriously. But I can say that is like kind of jockish approach to negotiations has paid obvious dividends for Ohio. It took forever, but he managed to get all your political subdivisions in line, or at least 95% of your litigating subdivisions in line to settle early with McKesson, Marisourceburg, and Cardinal Health. That's cool. And a few years back, Dave Yost actually launched some pretty vicious attacks against cities and counties' right to sue at all, and tried to stop the multi-district litigation, which is ironic given the fact that it's in Ohio. But all of that served to promote this idea that states are the chief negotiators and they should be the quarterbacks of states in the opioid litigation, and cities and counties cases don't really matter. And whether or not that's true, again, it's kind of a normative question, right? But he did do a tremendous amount of work cutting into localities' right to sue. And the last thing I'll mention, thank you, Amanda. I appreciate the time note. So the last thing I'll mention is that Dennis is absolutely right. There are things about your memorandum of understanding that are at least worrisome to me. There is a high level of ambiguity regarding how that One Ohio Foundation will be spending its monies, and how the 15% that that's going to the state, how that'll be spent as well. I'll do this at a pretty fast clip because I know I'm over time at this point. But regarding that One Ohio Foundation, Section D describes its rules, et cetera. Section, the item 11 in Section D talks about how the board has tremendous discretion as to allocation. But what the MOU doesn't tell us is how much of that 55% must be funneled through to the regions, which means that theoretically, the foundation can sit on its 55%, not spend it efficiently, and not save lives in the short term. And this is a genuine fear. This is exactly what happened in Oklahoma with its Purdue winnings. And then, Dennis, to your question about that 15% going to the state, the only thing I can find about that was in Section C9, which states that attorneys' fees related to the state's cases shall be paid directly from the state share or through other sources. So that 15% going to the state theoretically could all be spent on attorneys' fees. So with that, I'll leave you. Thank you so much for the little bit of extra time to go over, but it's such a pleasure to email me with any questions. I'm looking forward to the Q&A.
Thanks very much, Christine. It's very informative to know that we do have, Ohio has a very special place, getting more money, setting the precedent. So it puts an extra responsibility on Ohio residents everywhere to make sure we do it right so that we can, help other states go forward.
Absolutely.
So I'll try to screen share again. I probably can't figure out how to do it. So I'll just read, but so I'm really happy that we have the father and son, Scott and Wes Weidle, here with us because they are really what this opioid legislation is about. Wes lost his brother, Daniel. Scott lost his son, Daniel. So Scott not only lost his son, he lost his brother and his stepson to overdose. So it's really hard to think of someone who's been more deeply impacted by what's happened than you, Wes. So our condolences go out to you. You really express in your book how devastating those consecutive losses are and why you're so committed to the building. And again, Little Lost Boy, A Dose of Reality is a wonderful book that Scott and Wes co-wrote together. And I was just reading it. It's quite powerful. Scott has been an advocate for expanding access to treatment. He was key in getting Daniel's law passed, which expands access to Vivitrol. He also created Daniel's Peace Memorial Park in his hometown of Germantown, where Daniel used to like to go to enjoy the outdoors. And Scott, in his private life, is a business owner in Germantown, which is outside of Dayton. And I believe you're in the excavation business and car wash and done a little development. So just sort of an all around entrepreneur. And he also made a very kind donation to Harm Reduction Ohio within the last year to support naloxone distribution. So thanks for that as well. And Wes Weidle, his son, I don't know the answer to the question, but I suspect it was a physician's assistant now who's specializing in psychiatry and addiction medicine. And I think it's pretty likely that your family experience helped you go on to help others. And you also co-author. Thank you for coming back from Seattle to Ohio. Usually the human flow is in the other direction, but we're glad to have you back in Columbus. And Wes went to the real Miami University in Southern Ohio, the football school that produced Big Ben Roethlisberger, and he got his master's degree in to be a physician's assistant at Ohio Dominican University. And just before I set him up, I wanted to read like a quote from their book that I thought really expresses what this panel is about. So this is Scott and Wes writing about Daniel. Month after month, year after year, his medical providers kept writing him prescriptions for opioids. I do not believe that during this time, his prescribers were being malicious or neglectful. His providers were simply being told by pharmaceutical companies that opioids were not addicting. Pharmaceutical sales reps who were motivated and compensated by commission-based pay would come into their assigned doctor's office and explain these magic pills didn't cause addiction, were safe, and were effective for use in a primary care setting. And thus the thus was the birthplace of the opioid crisis. So I think that is really a beautiful description. And I turn it over to you, Scott and Wes, to get your thoughts on the settlement and what happened.
Yeah, thank you. I appreciate that introduction very much. And thanks for having us on the panel today. We really appreciate that. I had a little bit of a introduction planned, but Dennis did a great job. So I will just kind of cut to the chase. I'm going to speak mainly more in a micro perspective format compared to Christine, talking about just kind of what our views are on the opioid settlement and kind of what we would like to see in terms of how this money is spent and what to do with it. So in regards to the opiate settlement, we're of the belief that this can be a good thing, but I believe that it's, we're a long way off from really seeing how this is going to shake out. It still has, I think, the potential to be a really catastrophic failure and a waste of funds, to be completely honest. And I'll expand on that in just a moment. But first, I do want to acknowledge the fact that, I appreciate the fact that the settlement was made with these first three organizations, as opposed to, waiting it out and prolonging the process, because people are dying on a daily basis now, and numbers are increasing now. Just in the second quarter of last year alone, the overdose death rate in Ohio was the highest that it's been in 10 years. So, I do appreciate the urgency to settle and get the funds rolling so that people can get help. This is a life and death issue that doesn't have the time to wait for the justice system. On the other hand, I am frustrated by the fact that the companies that were responsible haven't really admitted fault and will remain some of the most wealthy and powerful companies and families in the nation. No amount of money will give us our family members back, and there's really no getting back the 1 million life years our state has lost because of this. And there are a lot of responsible parties still out there of whom played a gigantic role in letting this epidemic happen. And so I think attacking only the pharmaceutical companies and the distributors seems like a little bit of a scapegoat tactic on the part of the state, to be honest. So it's not perfect, and it's only a drop in the bucket, but it is better than nothing. And so regardless, the settlement's done, and I believe our energy and our time should definitely be focused on making sure that this isn't a complete blunder, because I definitely think it has the potential to be. And so in terms of what I think should happen in terms of where do we go from here? Where should this money be allocated moving forward, and how should we use it most effectively? I think that it really starts with the fact that it's our belief through our experience that the addiction treatment system that we have currently is really fundamentally flawed. And so if we just pour our money into the current structure, of which is already flawed, I don't think that we're necessarily going to see much improvement. And so in our opinion, it should kind of be a two-component approach. Number one being that education is most important, primarily for providers. So, and we're not talking, your stereotypical CME lectures that providers will just, put on mute in the background as they finish up their charts for the day. I think money should be poured into developing actual effective and engaging learning programs that really give tangible and concrete tools that can be used across specialties, including, education on the front side, addressing issues like overprescribing of opioids and their risks, but also educating on ways that settings such as primary care can better address the risk factors for addiction, anxiety, depression, ADHD, and ways to treat addiction within reason within that same setting. So for example, being able to equip primary care providers to use things like non-controlled, naltrexone, something that's not controlled, that's really, really low side effects profile that most primary care doctors don't necessarily feel comfortable or educated enough to utilize in the addiction treatment world in the primary care setting, yet is a very, very essentially benign medication that I think that we could easily train up that subgroup for. And the other part of that education for providers is also educating providers and organizations on ways that we could probably use primary care to implement integrative care models of care, in which you would essentially have kind of a psychiatrist or an addiction psychiatrist in-house within a primary care setting, available virtually or via or in-house. And then education additionally for the community at large as a way essentially to just decrease the stigma associated with the disease and therefore increase the likelihood that people will seek help and get help in the first place. Things like curriculum and speakers in schools, community events, even some creative approaches such as like wellness parks and things that we have here. And the second part of this, so the first being education, the second part that I think really needs to be the center of the focus is developing a standard of care that's quality driven. So, and I promise to be brief here, but essentially when you look at the types of the treatment model that we have right now, we have kind of two types of addiction treatment for MAT specifically, for medication assisted treatment. We have OTPs, opioid treatment programs, which are federally regulated, in our experience provide a pretty high level of care and a wide variety of services, but they're pretty few and far between. And then on the other side of the spectrum, we have OBOTs or office-based opiate treatment. And in contrast, this is not federally regulated. It was created in order to increase access to care, which it did, but it's, in our opinion, in our experience, has resulted in kind of a low quality of care and even harm in some cases. And so I would propose that one of the avenues of funding for this would be to either take the OBOT standards and completely overhaul them. So for example, that could be done through developing like a high quality therapy curriculum that's done via like a telehealth platform for patients that can utilize and participate, in the comfort of their own homes, as opposed to the alternative of sticking 30 people that are struggling with addiction into the same room and expecting them to be able to learn and to focus, which, we know isn't always an easy thing to do, given the effect that addiction has on the brain's capabilities. And I think given the advancements that we've made with virtual technology due to the pandemic, this is obviously much more realistic now compared to ever before. Or the alternative, we essentially kind of draw away completely from the typical OBOT model, and we pour this kind of money and effort into building the integrative care model here in Ohio, where we equip and train willing primary care offices across the state to partner with a psychiatrist or an addiction psychiatrist, either virtually or in-house. And this is essentially what I'm doing here in small town Ohio, down in Dayton. And it is a really, really common model of care actually out in Seattle, where I was just living, but you don't see it as often around here. Extremely successful, especially within the model of psychiatry and addiction medicine. But essentially it would just allow, again, willing primary care offices to be able to have access to a psychiatrist or an addiction medicine specialist within the same network. Either of these models, I think, are options that can also include room for increased funding and even creation of additional OTPs, because, right, in our experience, at least, those are already doing a pretty good job. Regardless of kind of where you stand on the issue, the one thing that I think that we can all agree upon is that we need to be equally, if not maybe more, focused on preventing addiction and addressing it from the front end, right? We always kind of use the term turning off the leaky faucet, as opposed to just putting out fires or focusing on treatment on the back end. And so another way to think about that is essentially just looking at it as a three-prong approach. This is kind of summarizing stuff I've already said, so I apologize if this is a little repetitive, but essentially the three-prong approach being, one, addressing the issue of overprescribing prescription opiates, especially in the primary care setting, specifically for chronic pain, of which, right, we all know that they're not indicated and not recommended, yet continue to be prescribed. We all know that opioid prescribing continues to be super widely underregulated and poorly monitored. So I think funds need to address that. Two, making sure that people have access to care specifically for the major risk factors for addiction, right? We know now that if people had proper and adequate treatment for their depression and anxiety, let's say, they'd be less likely to be reaching for the upper or the downer on the street to self-treat in the bottle or elsewhere. And similarly, the other common risk factor is ADHD. If they have adequately treated ADHD, they're less impulsive, therefore they make more sound decisions usually. And so being able to make sure that even in these rural counties, that these people have access to psychiatric and medication management is important. And then the third part of that three-prong approach is just simply reducing stigma through education so that people, again, feel don't feel ashamed to ask for help and get the care that they need before their brains start to really undergo these detrimental changes that are obviously much harder to reverse and treat once the disease has taken root. So that's kind of our summary of how we would, in an ideal world, like for these funds to be allocated and utilized. Actual implementation is obviously much harder than some of the ways that I verbalized that, but I think that most people can agree that those underlying principles are pretty sound. So
thanks, Wes. And I think you actually set up Dr. Hurst beautifully, because he spent much of his career at the top of the Ohio Department of Mental Health and Addiction Services, and Ohio Department of Health, working on these issues and expanding it. And now, since he's retired, he's gone to Maryhaven, and he is the medical director of the methadone clinic, the OTP at methadone. So he's gone right back from the top of the bureaucracy right down to direct service. And it'd be fascinating to see how the policy work he did, what he thinks of it now from the other end of the spectrum. So I'll just turn it over to you, Dr. Hurst.
Thanks so much, Dennis. And thanks, Scott and Wes, for sharing your experiences here and your expertise that comes out of those experiences. What devastation that has to be. And I think what's even more disarming is that if there are 2 other people for every person who died of opioid overdose last year, that's 8 or 10,000 people in Ohio who are going through the same thing. And if we add all of the years beyond that, the number is really unfathomable. And Christine, thank you so much for giving that nice overview. It reminds me how grateful I am that I have not had to do a deposition or received a subpoena in about 6 months now. So, it was getting pretty close to that litigation this summer, and I thought I was going to have to go up to Cleveland and testify, and oh my gosh. But fortunately, the settlement came through, and that wasn't necessary. And I've just loved working with Dennis for these past few years. When I was with Mental Health and Addiction Services, I started to hear, gosh, there's this guy, Dennis, out there who's talking about harm reduction, and he's kind of adversarial. And I said, well, have we invited him to come in and talk with us? And the answer was, well, no. I said, well, why don't we do that? So Dennis came and we had a great conversation, and I think we've worked really well together in terms of advancing harm reduction in Ohio with the political constraints that are very real. Dennis mentioned that I was doing harm reduction before it was cool. Did I miss something, Dennis? When did it get cool? I think we still have a lot to face with that. Needless to say, we're in the midst of this unprecedented crisis of opioid addiction, opioid-related social crises, opioid-related deaths in the whole country, and especially here in Ohio. And as I look back on my career, when I first got into this field of addiction medicine in the early 1990s, which really means the late 1980s, but I didn't want to admit that, we didn't have many addiction specialists, and mostly, almost exclusively, we dealt with alcoholism. And at that time, we had about 100,000 deaths in our country due to alcohol, about 400,000 due to nicotine or tobacco, and about 4,000 due to other drugs. Now, folks, last year in Ohio, we lost 4,000 people due to overdose of drugs, just in Ohio. So that tells you where things have gone since then. But by the mid-1990s, the opioid crisis was starting with its roots exactly where Scott mentioned. Changes in medical practice that were fueled by the pharmaceutical industry, by its marketing, encouraging liberal prescribing of these highly potent and addictive opioids. And although we didn't know it then, the crisis had already started. And then by the early 2000s, there was an observant professional at the Ohio Department of Health who noticed that deaths due to accidental drug overdose had progressively increased over a number of years and sounded the alarm. And the alarm went unheeded. But by the later 2000s, it was obvious that the prescribing of opioids had increased markedly, and in a parallel fashion, opioid-related deaths had increased. So even after that, prescribing continued to increase, and so did deaths. And eventually there was a transition from prescription opioids from licensed practitioners to pills from illicit sources, and then to the cheaper and more potent opioids, first heroin, then fentanyl, more potent in terms of their euphoric effects, more potent in terms of their lethal effects. So there was a response, and comprehensive programs were established, many of them based upon the science that existed then. But frankly, there was a lot of difficulty, I think, as Scott was alluding to, with uptake of even the scientific evidence-based practices at that time, which was really concerning. And we continue to see that today. You know, we continue to see residential treatment providers which refuse to accept patients who are on medication for opioid use disorders, an evidence-based practice. And we hear sometimes that they feel they can get as good outcomes with extended residential treatment as they can if a person is on a medication such as Vivitrol or buprenorphine or methadone, yet we don't see data confirming that. Well, we did a little bit better in 2017, second half of it in 2018, with fewer deaths, but then it started to increase again a bit in 2019, and it really surged over the past couple of years. And we've also seen a new demographic with more opioid-related deaths among Black Americans, especially Black men. So now back to those grim statistics. I mentioned 4,000 drug-related deaths annually in the US in the early 1990s. By 2000, there were 90,000 deaths due to overdose alone, over 20-fold. And we start comparing that to COVID. So as of this week, we had lost about 750,000 individuals in the US to COVID. Since the opioid crisis began in the mid-1990s, we have lost 850,000 due to opioid overdose. So more individuals have died from opioid overdose during this crisis than have died from COVID to this point. Now, I get it, that's kind of comparing apples to oranges, but the raw number of deaths from either of them is really heart-wrenching. And with both of those, many of those deaths are avoidable. So what can we do about it? Well, there have been things that have been done already that have been helpful: increased availability of evidence-based treatments, expanded access to healthcare due to Medicaid expansion, availability of naloxone to reduce overdose. Those are only a few of them. We had a nice infusion of funding from the federal government in the 21st Century Cures Act, and that helped expand a lot of services. But given the trend of the addiction epidemic, it's obviously not enough. So a couple of broad points before I get into a few of the specifics. First, we got to be in this for the long haul. This crisis has already had a life of 25 years. So while the COVID pandemic is going to end, as do all pandemics, this has had and will have a lot longer life. It took decades for smoking in the US to decrease substantially, and it did so gradually. And it's going to be similar to that with the opioid crisis. It's going to take a while. It's very unlikely that we're going to develop a magic bullet that will turn the opioid crisis around quickly. The factors that contribute to the development of addiction in a person and in a society are many, and they are complex. And we need to deal with all of those, as Scott was mentioning earlier. We need to utilize interventions that are established as impactful. So we look at COVID again. We're aware of effective measures for prevention, like mask wearing and social distancing and immunization. And we now also have effective treatments. There are effective prevention and treatment interventions for opioid addiction too. Yet, as is the case with COVID, we still have had too little uptake of these effective measures. And as a result, we can't expect to see the outcomes we otherwise might. So that speaks to the importance of investing in strategies that we know work and investing in some strategies that have the potential to be effective. So what are those broad areas? Basically, there are four of them. There's prevention, there's early intervention, there's evidence-based treatment, and then there's harm reduction. So the paper that describes the abatement strategies is much more robust than only those four strategies. It's really comprehensive. It's difficult to find fault with any of the proposed interventions. It stresses sustainability, which is going to be critical. But as I mentioned earlier, the approach has got to be for the long haul. We got to be certain that what we're doing what we know will work, And that has to be the foundation of all the efforts. Specifically, we need to collect data. And my friend Orman Hall talked at the Public Policy Conference last week, and I'm sure that he talked about data. We have to look at that data to know whether an approach is working or not. And if not, do we revise it or we demand it? And that should really be from a quality improvement perspective. You know, we're not trying to be disciplinary or anything like that. We're trying to improve things so we get better outcomes. And we use those things that are scientifically based that provide those outcomes and do more of that. We should be getting the better outcomes. Public information campaign is identified, and that is really essential. The addiction crisis had captured the public attention in the 1910s, and it continued for quite some time. You couldn't read a newscast, you couldn't watch a newscast, read a paper without reading about it. And during that time, I was worried about when the public fatigue was going to set in and when the outrage would diminish and when the public would accept, well, this is just the way it is. We lose this many people due to opioid overdose. And I'm afraid if we aren't there, we're on our way there. And certainly COVID had something to do with it, but I think it was starting even before that. So now let's get back to the question, how will we know if we're doing the right things? My recommendation is that the state identify the essential aspects of a comprehensive plan, comprehensive meaning targeting all those 4 areas that the regions can utilize to guide their efforts. You know, certainly having those 4 things is important, but we can also assume that those areas that have the most robust efforts in those areas are going to get the best outcomes. So it's not just about establishing a prevention plan, it's assuring that those prevention activities are broadly implemented. It's not just about having medication for opioid use disorders available, it's about patients having adequate and timely access to such treatment with appropriate dose, duration, monitoring, and other kinds of therapies. So now I'm going to get a little geeky here. I'd suggest that a fidelity scale be developed for those essential activities to help those regions objectively identify their areas of strength and weakness and develop approaches accordingly. I certainly believe that communities know their communities best and what they need. But I also believe that all of us as individuals, as organizations, and as communities have blind spots. And if we have objective ways that look at this and measure this, it's going to be much more likely that we develop the robust kind of outcomes that we need. And so as the state would look at those, the state advisory board, the expert panel, it can help us look at what statewide issues need further development broadly, what specific areas a region might need help with, and then to provide that assistance to them. And so I'm just going to briefly show a few slides about what I mean with that and what a fidelity intervention might look like. So with this, you might look at prevention and you go to an area and you say, okay, what kind of prevention activities are provided in grades K through 5? And then you'd ask the area to identify them. And there are certain evidence-based prevention activities that occur. One of them is something called the good behavior game. So say, yeah, we're doing the good behavior game. Say, okay, now what percentage of classrooms in your area are using this evidence-based prevention, this good behavior game? And so, I think that we would expect better outcomes if a higher percentage of students were exposed to that. So we would do a rating scale on that. Again, it's not meant to be punitive, but what it's meant is to identify holes and areas of improvement in order to bring that to more of the community and hopefully get a better outcome. And then you do the same thing for middle school. What kind of prevention activities are you using and how many classrooms are using them? And you do the same thing for high school. And you might do the same thing for treatment. You might say, how many types of medication for opioid use disorder are offered in your region, either directly or by referral? Are you offering none? Are you offering one? Or are you offering all 3 forms of it? The more that are available, the more comprehensive treatment people are going to be able to get. And then how quickly can people get into treatment? What's the wait time for referrals for patients to begin medication or to even get in treatment, period? The shorter the time frame, the more likely they are to enter treatment. Putting patients on a wait list or saying come back in 3 days when they have active addiction is much less likely to be effective than say, let's see you this afternoon. Let's see you right now. What's the maximum period patients may remain on treatment? In some circles, there's still a belief that this should only be for detoxification, or people should only be on it briefly, or it's not real treatment. Well, personally, I believe that this is a chronic disease, and I think the data bears that out. And chronic diseases often need chronic treatment. Not everyone needs that. It needs to be individualized, but there should not be an arbitrary number that is mentioned there. And then look at other therapies. How many types of evidence-based psychotherapy are you offering? Are you just offering one, or are you offering the whole spectrum of them to match them better to the individual? So you can see this kind of creates a rating scale for areas of strength, areas of weakness, what can be worked on, and how you can better, more comprehensively treat your community, lead to prevention interventions, and have a good outcome with it. And of course, I couldn't resist mentioning harm reduction, since that's the sponsor of our conference here. What forms of harm reduction do you offer? Do you offer none, or do you offer a lot of them? Now, I think, and I hope every community in every area is offering naloxone at this point. But we don't have a lot that are offering syringe services. Syringe service is mentioned in the abatement strategy from the state, which I was really happy to see. Are they offering PERP, which is pre-exposure prophylaxis for HIV, or they offering hepatitis and screening and things like that? Again, the more comprehensive, the better off we're going to be. And we also know that people who are involved with harm reduction are ultimately more likely to enter formal treatment. So there are a lot of good reasons to do that. So this is just kind of my geekiness, but I think something like this, which would be objective, is going to be much more helpful in terms of helping us have comprehensive approaches. Well, we talked about $1 billion. Senator Everett Dirksen actually has been attributed this. It's not clear if he really said this or not, but $1 billion here, $1 billion there, before you know it, you're talking about real money. Well, this is real money, but it should be used to augment existing funding. It should not replace it. And this is going to be a real temptation when the budget comes around to say, gosh, we got this 45 million for this. Do we need to continue to put 45 million to opioid use, or can we take that and use it for something else? I hope that that isn't what happens, but I would be concerned about that. My other concern is that in the end, even $1 billion may not be enough, but it's sure going to help. And we'll take it, and we certainly do hope that it's spent wisely, and we can do well with this and start turning things around. So thanks much. I guess we're going to have some questions and a little discussion now.
Thanks very much, Dr. Hurst. And I'll just, before we get to the audience questions, which we have some very good questions, I just wanted to ask you, related to this, like with your scale, would you incentivize, like give less money to people who aren't doing well on your scale? And
I would suggest doing exactly the opposite. I wouldn't give them unfettered money, but what I would do would be try to bring in professional expertise to help them develop those areas. I don't think you would decrease funding to areas that are struggling with it. You need to give them more help. But as Scott was saying earlier, money is not help. Money can be used to help, but you need to bring the other features with it to do so. And I mean, there are facilities in this state which have developed such fidelity rating scales for instance, integrated dual diagnosis treatment that was developed by the Center for Evidence-Based Practices at Case Western Reserve University. So, again, that was just me throwing together a few things, but you could do this in a really objective way and use it to guide assistance in appropriate areas. And those areas that are doing fine, you want to continue to support that but you would not necessarily, you would want to prioritize the areas that we're not doing as well.
So I want to just direct one reader question to you, Dr. Hurst. How long will it take to give out the money? It's easy to spend money fast and irresponsibly. So the question is, like, from being at the top of near the top of a bureaucracy, how quickly can a bureaucracy, the elephant, actually dance and turn it around?
That's a great question, which means I don't know. So I think part of it lies in, what does the corporation look like? And is the corporation bound by all of the regulations and laws of the government of the state of Ohio? So, for instance, if you're going to have a contract for more than $50,000, that has to be approved by a controlling board. And then after it's approved by the controlling board, then you have to do an RFP for it. So this delays things a lot. If the corporation is not inhibited by those kind of things, it would be much easier to distribute that kind of funding. And that would make things a lot simpler. Now, yeah, I don't know how this is structured. I don't know if that's going to be a possibility or not be a possibility. So if that can be used to escape some of the bureaucratic aspects, it would be a lot easier.
That gets into another question that leads sort of like Christine may be able to answer that. Question is, each state getting the same amount of money, but just as important, is each region getting the same amount of money in Ohio? I think the language of the agreements are equitably, and it's all very, very vague. So even Dr. Hurst's incentive system, give more money if there's greater need and they're doing things on the scale. Is that even possible under the language of the law?
Under the language of the MOU, which admittedly is incredibly ambiguous when it comes to that foundation, it does look like the board can set up for itself its own governance structure. Same with the regional boards. I do know that regional board representatives have recently been appointed, at least in one county, but it does look like they can set up their own rules to decide for themselves how they want to divvy up the funds. But that's for Ohio's 55% that's going to the One Ohio Foundation. As far as the global settlement as a whole, like the national allocation of it, the $26 billion is actually $26 billion less, about $2.2 billion in attorney's fees. And the remaining sum is split up in a range of payouts. For instance, 0.2, like the smallest pie, the smallest slice of the pie would go to Wyoming. They have 0.2% of the settlement, which for them, their AG's office calculated that to be $45 million. And at the upper end, the biggest slice of the pie goes to California. They get almost 10% of the settlement, which is roughly $2.3 billion, according to them. I think it's an entirely valid question, like, why is California getting more money than West Virginia, for instance? The formula used to allocate these funds weighs population quite heavily. So the formula would look at, how many pills were shipped to a jurisdiction, the formula to figure out how much money a state gets. So that formula factors in three things, like how many pills were shipped to a jurisdiction, how many people have died from opioid use disorder, and how many people are currently living with opioid use disorder. And those are heavy, those are population-based factors, right? Like how many people in a state, which is why California is, despite the fact that was proportionally less hit than West Virginia, for instance, is getting so much of it.
So I'll ask a question for Christine and maybe Dr. Hurst. Is 2 years ago, Jonathan Blanton, the Deputy Attorney General, put out a letter saying these agreements can only be done by constitutional amendment. Now we're doing it all, but not even by law. It's just like an agreement, and then we're getting the township associations. So Ohio, 15 years or so ago, it took the tobacco settlement and used it to close a budget deficit. How much of a lockbox do you think the opioid settlement money is in for the opioid uses?
I'll jump in. That's a great question. And as a wise man once said, that means that I don't really know the answer. Thank you, Mark, for that joke. But I think as far as, that statement has circulated quite a bit, that in order to ensure that these opioid settlement funds are used solely for abatement, it requires a constitutional amendment. The way that'll play out to your point, it doesn't seem that states are necessarily taking that approach. And the reason why they're not is because the reason why a constitutional amendment is referred to at all is because what it's really saying is that a state needs to decide for itself how much power each branch of government will have when it comes to the opioid settlement spending problem, right? So a state, the three branches of government, executive, legislative, judicial, the state in its executive capacity, the AG, goes out and gets money for a stated purpose, right? To abate the harms of the opioid crisis, which we know is a preventable overdose crisis. But in any case, so the executive in the state's executive capacity gets the money for a reason. But at the legislature, if the political priorities, if they have this like a political divorce between the branches, or the branches aren't getting along, the legislature can, constitutionally speaking, conceivably spend it however it likes. There are restrictions for how the money should be spent. The settlement agreements themselves include some language that state that at least 70% of the funds must be used for abatement. Fine. Whether or not that's going to happen, this is America in 2021, right? Like we're reaching like a point of extinction for the effectiveness of like local campaigns. Like I think that in a gated community like Scandinavia, for instance, like the money can be spent rather responsibly because people actually, feel more connected to one another. But with the scale of the settlement and with the country the way it is now, we'll just really have to see. It's a good faith. TLDR is that we're relying on states' good faith statements that they will spend it well. The way to force them to spend it well is by constitutional amendment. That is correct. But right now we're hanging on by threads here, threads being contractual agreements between states and the localities as to how to spend money.
I guess I would, I can't answer any of the legal questions. But, what my concern as a recovering state bureaucrat would be what I had mentioned earlier. Not that it in and of itself would be used to help balance the budget, but that other things would be cut, specifically other state funding for the opioid crisis would be cut, and then that this funding would supplant that funding. That would be my biggest concern with it. It's good that this is spread out over the next 10 years. I think that, your concern about bankruptcy of J&J in another 13 years is a good one, Dennis. But I would also be concerned about what's going to happen with state budget in 2033 when there's that large infusion of cash, should that transpire.
Let me ask just a couple of more questions. And I think a lot of it comes down to maybe like your insight on the politics. If there's political pressure to use this on opioid purposes, then I think there'll be a lot of elected officials will follow. But if there's not, then it goes. So one of the questions, let me see if I can find it here and read it. How do impacted individuals get a seat at the table? So I think that's, Dr. Hurst, really a political question, and it's not the most friendly political environment, but I do think impacted populations got more than 10 years ago, not as much as so from a recovering bureaucrat, like how do people influence who you used to be?
Squeaky wheel gets the grease. So I don't know who is the decision maker at this point about who's going to be appointed by it. If I wanted to be on this committee, what I would do is advocate with all of the people who are doing the appointing. So one would be the governor's office. I believe the legislature also has some appointments to it, and doesn't the AG have some appointments to it too? I can't.
They have one. So Dr. Hurst, they told me that they're not taking applications. They're just talking about it and going to do it. So not that I want to be adversarial, but I was thinking of creating my own application process and following and forwarding the applicants to them, because I do think there should be an application process. It's not the Lake Erie Helicopter Commission I mean, this is an important doing, and so that's my concern. But
I think you're right. I mean, I think it's an issue of speaking up. I think it's an issue of letting your state senator know about it, letting your state representative know about it, and letting the governor's office know about that. And in fact, asking your legislators to advocate with the governor's office on your behalf in order to do that, or on the behalf of the purpose that you're serving. You know, it doesn't have to be me who's appointed to this, but I feel very strongly that either a person in recovery or a family member of a person in recovery, or ideally both, be appointed to this commission.
so let me ask the last question, then we'll wrap it up and direct this one to Christine. So the question from the reader is it too late to get transparency or reporting requirements?
Technically, no. The global settlement agreements do include provisions that state that states can amend their statewide allocation agreements. They can amend their plans and resubmit them to be like reaccepted and like rehugged into the global settlement framework, I suppose. So technically, there is the opportunity to amend the One Ohio MOU. You know, that I guess it's about like assembling the squeakiest wheels to make that point, right? I do think the reporting requirement thing is going to be important because, to Mark's point, I think it's a live question as to whether or not we have the political, emotional, empathic energy in this country to continue to be angry about how these settlements will be spent in a way that will ensure responsible spending. So we do need to set up the processes now to make that happen. And according to the global settlement agreements, Ohio can still amend. And another amendment I would propose is some explicit language about supplantation. Mark, you talked about this briefly. Supplantation is a problem that occurs when a state or local government uses other funds to replace money it should have been spending anyway on something. Supplant is to replace, supplantation is the evil twin of supplementing funds, right? Like supplant is to replace, supplement is to add to. You know, supplantation is a real problem. And typically when people make that argument, when they want to be squeaky wheels about it, they will refer to the big tobacco litigation and the settlement administration process. But examples abound in the opioid context as well. I think the most laugh cry example that I like to mention is when Joe Manchin was governor of Virginia, he tried to use some of his state's Purdue settlement winnings to buy himself a personal gubernatorial helicopter. In that case, settlement funds would have been supplanting whatever funds ought to have been set aside for gubernatorial helicopters, but instead, you know, he had attempted to use Purdue settlement winnings to pay for that. It's a live problem, and that's another thing I would, you know, be very squeaky about.
Christine, does the settlement allow a certain amount of supplantation, 15%? So they got 150 million to buy helicopters with. Yeah,
it does. The settlement agreement does, you know, technically it does provide enough of a crack for supplementation to exist, especially in the One Ohio plan. It does not. It has like rather like ineffective language about how the money should be spent. It does not explicitly state this money shall be used to expand access to treatment rather than replace money we as a state should have been spending anyway on the effort.
A final question, Christine and Dr. Hurst, can these be put into the bylaws of the not yet created One Ohio, or do they have to be done legislatively, or at least through administrative code?
Legally speaking, can be both. I think legislation is scarier. It poses a stronger threat, and I think legislation has more teeth than does a contractual agreement.
Final question, Dr. Hurst, do you think that would you be happy to see the legislature sort of deal with these technical issues, or is it best left elsewhere?
Nothing like putting me on the spot at the very end, is there, Dennis?
You're retired.
Yeah. So I'm trying not to say something that's going to get me in trouble, but I'll just say it anyhow. Our legislature has not been a beacon of excellence in terms of public health policy over the past year and a half here. So I would have concerns about that. I really feel that having this corporation, letting this corporation do its work would be the ideal. The legislature has the ability to appoint individuals to this corporation. So they have a voice in it through the people who they appoint to it. And the numbers that are appointed by the different areas, to me, strike a pretty good balance in terms of at least the legislative and executive branch. Judicial branch is really not represented within this. And we may need the judicial branch as this proceeds, because there may be litigation that occurs in terms of how this all unfolds. So, I think everybody has their voice in this, either directly or by appointing. So, let's let the committee do their work. Let's appoint good people to that. Let's let them do their work with it. Let's make sure that we as citizens are keeping an eye with what's going on. Let's make sure that we're doing things that are effective. Things that are politically popular are not always effective. And we need to be sure that this is effective, because the end result is we need a lot less people dying from this disease.
I appreciate that, Dr. Hurst. And in closing out, I appreciate the optimism. I thought One Ohio is I was excited to see it. And with transparency, it does have to follow open records laws and open meetings laws. And with all the people involved, there sort of is a movement toward transparency. So I'm sort of optimistic about the structure that is established despite all the worries. So thank you for everyone for participating today. And this will be available on Facebook Live, I think almost immediately, and then we'll post it on our website tomorrow or the next day. Thank you.
Thank you.